us. So I'd like to take a moment to welcome everybody to this virtual learning collaborative focused on improving care for developmental disabilities and dysmorphic features, brought to you by the Midwest Genetics Network, American Academy of Pediatrics, and the Minnesota Medical Association. The Midwest Genetics Network is a seven-state network, funded by the Health Resources and Services Administration, or HRSA, focused on improving access to genetic services for medically underserved individuals. This continuing education and quality improvement project is one of many resources that have been developed by the Midwest Genetics Network Stakeholder Education and Engagement Work Group. And if you have, if you have interest in participating in that work group, please feel free to reach out to any one of the team at MPHI, and we can help you do that. So today's presentation on what to expect at a pediatric genetics evaluation is the second in a four-part series. If you happen to miss the first one on developmental screening during a well-check visit, there is a recorded version available on Midwest Genetics Network's Virtual Learning Collaborative channel. And we'll put the link to that in the chat for anybody that, that might want to go back and check that one out. Excuse me. So there are nearly 60 providers participating in this project, and they come from at least 10 different states around the country. So there's a big group of us that are participating in this project either for MOC4, MOC2, or CME credit, and actually some just participating because they want to learn about the topics. So there's a couple housekeeping items that I want to mention before we actually start the presentations today. For those of you participating for MOC4 credit, many of you have started entering your first audit data, and we've noticed a few inconsistencies there. There are several people missing Measure 1 information, and that may be intentional. Maybe you didn't enter it yet, but if you think you entered it, when you go back in later to enter your Audit 2 data, if you can just check your Audit 1 data and make sure, first of all, you have a number entered in all 5 measure spots, and then also just make sure that you didn't make a typo, because a few of you have percentages that calculate out to be way over 100% for the percent of the measure. After Audit 2 is done, if we still notice any inconsistencies in the data, we'll reach out to you directly and let you know. It is always a possibility that there is some type of glitch in our data system that has nothing to do with the data you entered. So if we still notice those things after Audit 2, we'll just reach out to you to try to sort that out and figure out what's going on. So the other thing, the last housekeeping item that I want to mention is that if any of you have colleagues that would like to attend these presentations or participate on the project either for MOC2 or MOC4 credit or for CME credits, it would be really helpful if you not share your Zoom link with them and instead share the registration link for the project with them, or even just give them Danielle's email. Both the project registration link as well as Danielle's email is in the chat for you if you need it. So in order for us to offer opportunities like this free of charge for you, we need to be able to collect that information we get in the project registration to report up to our funder. So we want as many people as possible to participate. It would just really be helpful for us to share it, not by sharing the Zoom link, but by sharing the registration link. So with that, it is my great pleasure this morning or this afternoon to introduce our speakers, Ms. Sarah Zorin and Dr. Jess Scott-Schwer. Ms. Zorin is a certified genetic counselor at the University of Wisconsin Weissman Center Medical Genetics Clinic and has been the coordinator of the Genetic Systems Integration Hub since 2016. Ms. Zorin earned her Bachelor's of Science degree in genetics and a master's degree in endocrinology and reproductive physiology from University of Wisconsin-Madison. And she's worked in both basic research as well as academia, and is a longtime member of the Midwest Genetics Network Stakeholder Education and Engagement Work Group. including part of the core team that developed this particular quality improvement and continuing education project. Dr. Scott Schwer is an associate professor at the University of Wisconsin Department of Pediatrics, Division of Genetics and Metabolism. She completed medical school, pediatric residency, medical genetics residency, and a biochemical genetics fellowship at University of Wisconsin School of Medicine and Public Health. Her interests center around access for genetic care and newborn screening. She's collaborated with clinicians and laboratorians in Department of Pediatrics, State Lab of Hygiene, state and county public health, lay and certified midwives, and Lafarge Medical Center to improve newborn screening and care for patients with genetic and metabolic disorders within Wisconsin's plain communities. She's also working to improve telemedicine services for genetics and approval for genetic testing for patients in Wisconsin. Dr. Scott Schwer is a key partner in several Midwest Genetics Network initiatives and was recently appointed to the advisory board for the Midwest Genetics Network. So without further ado, I will turn this over to Ms. Zorin and to Dr. Scott Schwer to tell us about what to expect at a genetics pediatric evaluation.
Thank you, Matt. Could I have the next slide, please? So Jess and I have no conflicts of interest to disclose. Next slide, please. The learning objectives for this presentation are twofold. The first is that participants will be able to explain the process of genetic evaluation for individuals that are referred for concerning developmental screen and or dysmorphic features, as well as to be able to identify provider and patient resources for genetic conditions. I'm just going to take a minute to try to readjust my my screen. I have, well, I think we should be okay. Next slide, please. I wanted to start off by expanding on 2 points that Mimi made in her presentation last month. And the first one is that the American Academy of Pediatrics does recommend that children who are identified with any developmental problem be referred for further evaluation to identify the etiology. And this is because knowing the etiology may guide additional treatment or management. And the AAP has put forth several statements, guidelines, really beginning in 2006 and most recently in 2020 regarding the genetic evaluation of individuals with either developmental delay, global developmental delay, intellectual disability, or autism. And additionally, the American College of Medical Genetics and Genomics, which we refer to as ACMG, in 2013 also put forth a practice guideline for the clinical genetics evaluation of children who are identified with autism spectrum disorder. Next slide, please. I wanted to call out a statement made in the ACMG paper which says the referring professional should discuss expectations and possible outcomes of such an evaluation before making the referral. The referring professional should be aware of what is involved in such a consultation and the potential diagnostic yields and should share this information with the patient and or family. And it really was this statement that has guided the content for the presentation that you are about to hear. Next slide, please. The overarching goals of a genetic evaluation are threefold. The first really is to assess whether a genetic etiology can be identified and, if possible, establish a unifying diagnosis for the presenting features. Also, we aim to provide information. And so this can be information about the natural history or the clinical course or the co-occurring symptoms of a disorder, as well as being able to provide prognostic information, recurrence risk estimates, which are the likelihood that if the parents were to have another child, that any future children would be affected with a similar condition, or for the child themselves when they become childbearing age to have children affected with a similar condition, as well as being able to provide condition-specific resources and support to the family. And then, when possible, to also be able to guide or change treatment and medical management for the individual. In the next slide, really the overarching aim for all of us then is to be able to improve the health and well-being of the individual and his or her family. Next slide, please. So these goals also align well with and overlap with the benefits of establishing an etiologic or genetic diagnosis. And the first really benefit to the family is ending the diagnostic journey and avoiding unnecessary and redundant diagnostic tests. And I think that we really cannot underestimate the value of this benefit to the family. Other benefits to the family are that improving psychosocial outcomes, providing condition-specific family support, whether it be information and resources to connecting with other support groups, providing those recurrence risk estimates which may help guide families when they are making reproductive decisions, and testing other family members who may also be at risk. And then establishing a genetic diagnosis can also help families acquire needed services and also can improve access or provide access to clinical trials if that's something they're interested in. And then finally, when we're able to provide that genetic diagnosis, treatment and medical management plans may be changed, so we may be able to refine certain options. We may be able to provide information about other medical features that may be expected or other medical risks. And so, for example, there are some conditions that we may know when the child is in adolescence, there may be an increased risk for seizure onset, or perhaps when the individual reaches the 30th decade of life, there may be an increased risk for glaucoma. So knowing these things, then we can incorporate some surveillance to try and reduce those comorbidities. Next slide, please. The second point that I want from Mimi's presentation that I wanted to expand on was the diagnostic yield. And so, one question is, what is the diagnostic yield when performing genetic testing for children with intellectual disability or developmental delay or autism? And the short answer is that it is ever increasing. So approximately 20 years ago, when the tools in our toolbox were limited, the diagnostic yield was anywhere from 6 to 15%, that ranged by report. And at the time, the tools available to us were karyotypes, metabolic testing, Fragile X, and microarray. And just as a side note, in the last virtual learning collaborative, we will be going into much more detail about all of these tests. Next slide, please. Then in 2013, there was this paper, this was from the ACMG guidelines that I referenced earlier, and they quoted for individuals with, who had autism spectrum disorder and a full genetic workup, that the diagnostic yield ranged from 30 to 40%. So one point to make is that not every child will receive a full genetic workup, and this can be for various reasons. But the first tier testing for this is microarray and Fragile X. And so in the time span from about 20 years ago to 2013, The technology improved, as well as our understanding of microduplication and microdeletion syndromes. But also we had discovery of specific genes that were known to be associated with specific conditions. And so examples of those are the gene MECP2, which is a causative gene in Rett syndrome, which is identified in 4% of females that have intellectual disability and regression. Similarly, another gene called P10 is implicated in about 5% of individuals with autism macrocephaly, and specifically a head circumference of greater than or equal to 2.5 standard deviations above the norm, and in some cases a family history of specific cancers. And so if an individual had received the full gamut of available testing, there was a 30 to 40% chance that we would be able to identify a diagnosis. Next slide, please. Since then, there has been an explosion of information, not only in our technology and the testing capability, but also in our knowledge, as well as in infrastructure, so that now there are publicly available databases, and it is encouraged that the test labs are reporting to these databases so that we can share information. And that has really expanded our diagnostic yield. Next slide. In 2019, this paper was published in which the authors performed a meta-analysis of looking at the diagnostic yield of both exome sequencing as well as microarray for individuals that had neurodevelopmental disorders. And what they found was that the overall diagnostic yield was 36%. Next slide. They further broke this down into either individuals that had an isolated NDD as their only feature, in which case the diagnostic yield was a little bit lower at 31%, but for those individuals who had at least one other feature in addition to a neurodevelopmental disorder, the diagnostic yield was as high as 53%. And so they were concluding that the exome sequencing was outperforming the microarray, which has a diagnostic yield of about 15 to 20%, and they recommended that exome be considered a first-tier test. We should note that exome sequencing is not widely clinically, well, it's available, but it's not accessible to many. Insurance doesn't cover the exome testing. Many insurers don't cover that. And also the ACMG has not come forth with a guideline that is recommending exome sequencing as a first-tier test, although I do believe that that will be coming soon. And I also want you to know that there's also movement on the front of insurers covering genetic testing, including exome. And Jess Scott-Schwer has been one of the key people in our state who has worked with both Medicaid as well as a private insurer that's a major insurer in our healthcare system to establish criteria for exome sequencing. So I think we're going to get there. But two major points, or 2 points I want you to take away from this slide, is that a significant number of children who undergo genetic testing for intellectual disability, developmental delays, or autism will receive a genetic diagnosis. But the flip side of that is that there's also a substantial number that will not receive a genetic diagnosis, or not yet. Next slide. This is a simple graphic that is really intended to show the genetic evaluation process. And there's a few points I want to make here. And one is that not everyone who is referred to genetics will undergo genetic testing. Those that do undergo genetic testing, not everyone will receive a diagnosis. And for some individuals, there are multiple rounds of genetic testing. But even when we are not able to provide a diagnosis, there are some times when we are still able to provide medical management recommendations. Next slide. The second point is that this is a very lengthy process, and I think it comes as a surprise to many of our patients. You may be aware that there is an access issue in genetics regarding providers. So this is nationwide, and as an example, in the state of Wisconsin, we have approximately 9 medical geneticists that serve the entire state. They're not all 100% clinical. We have probably around 80 or so genetic counselors. So it takes a long time to, from the time the referral is made until the time the individual is able to be seen in clinic. Once the visit does occur, it could take months before genetic testing happens, and this is because, as I had mentioned, many insurers do not cover genetic testing, and so we need to get a prior authorization prior to obtaining sample, and then the testing itself can take quite a while. There are some tests that can take anywhere from 3 to 12 weeks for the results to return, and so this is very different from what patients are used to experiencing in the healthcare system. Next slide, please. So the visit itself, the initial genetics visit, it can last anywhere from 30 to 90 minutes, and that largely is determined by the number of providers that the individual will be seeing. So there could be just one provider, either a medical geneticist or a genetic counselor, but oftentimes there are multiple providers, which can then increase the duration of the visit. Next slide, please. There are a host of elements that we consider in a genetics evaluation, and one of the major ones is defining the phenotype and then determining whether the presenting features are isolated or suggestive of a syndrome. Many of you may be familiar with the term phenotype and think about Mendel and his peas and whether they're green or yellow, wrinkled or smooth. And it is true that the phenotype is a observable outward physical characteristics, but it is more than that. And so we define the phenotype as the observable characteristics or traits of a disease, which can include the morphology, but also development, biochemical or physiological features. So, for example, persistently high CK levels or low blood calcium levels, etc. But also can include things such as behaviors. So an individual with behaviors such as hand wringing or tearing off their fingernails or other self-injurious behaviors. And an accurate and thorough phenotyping is essential for genetic test analysis and interpretation, and it will enrich the diagnostic yield. And we'll talk more about that in subsequent presentations as well. Next slide. So for us in our clinic, but I think it's probably the same in other pediatric genetics clinics, is that we actually start preparing for the visit several weeks in advance of the patient actually coming. And this is collecting as much information as possible and obtaining a complete and thorough medical history, which can include prenatal and developmental history. But as you can imagine, with our electronic medical record system, we have access to much of the information, but because we see patients from all over the state as well as sometimes from neighboring states, we don't always have access to the entire medical record. And so any documentation that is sent to us in advance from the referring provider is very valuable to us. We also perform a comprehensive review of systems, and then there is the dysmorphology exam, which Dr. Stuberry will be discussing on our next virtual learning collaborative. Next slide, please. Another element of the initial genetics visit is to obtain and analyze a 3-generation family history. Next slide. And this includes relevant medical history of blood relatives, so siblings, half-sibs, parents, aunts, uncles, cousins, grandparents, etc., when available. We do recognize that the definition of family is broad and that it can mean different things to different people. We also recognize that sometimes this information isn't available, and that can be for many reasons, whether the family was created by adoption or whether the family is spread out geographically, either in the state, the US, or even the world. It could be that the person in the family who is the keeper of this information may not be available or able to share the information. There are some families that don't share medical information, and that can be for various reasons. And then there are also some families and individuals that have a lower proficiency in their ability to communicate health or medical terminology or conditions. And so we are aware of the limitations of the information that that we will get in a family history, but is still an important element, and so we do obtain this information. Next slide, please. And then there is a consideration of all of this information and asking, are the presenting features likely to have an identifiable genetic etiology? Next slide. And if so, which testing options are available to identify the genetic cause? Again, we'll be talking more about this in the last presentation. And then finally, the next slide, does the family want to pursue genetic testing? This is a big component in our decision to go forward. Next slide, please. It is possible that other recommendations may be made either instead of genetic testing, in addition to genetic testing, or before genetic testing is initiated. And these may include evaluation by other specialists, imaging such as MRIs, ultrasounds, X-rays. We could recommend other procedures such as sleep or swallow studies, or perhaps other labs as well. Next slide. And this is, again, a statement from the ACMG practice guidelines that I showed you earlier, that the PCP and the clinical geneticist should be prepared to partner in ordering, scheduling, and coordinating recommended diagnostic tests. And this may be a surprise to some, but really there's a few reasons for this. And one is that, as I had mentioned, our clinic, for example, is in southern Wisconsin. If we're seeing a patient that's coming from 5 hours away, to have a lot of these tests done locally is much more convenient for them. But also insurance sometimes dictates that some of these other recommendations are performed within their network. Next slide, please. There are some occasions where genetic testing is not recommended or not undertaken. And so what are they? It could be that a genetic etiology is not suspected. There are some presenting features or disorders for which it is known that the cause is environmental, and an example of that may be prenatal exposure to a particular agent, whether it be alcohol or some teratogen. But also there are some conditions that have a multifactorial causation. And so this is when there is more than one genetic factor and or an environmental factor that is participating to actually cause the constellation of features that we're seeing. It's also possible that a genetic etiology is suspected, but the causal genes have not been identified. And an example of this would be the hypermobility type of Ehlers-Danlos syndrome. Genetic testing may not be pursued if the family is not interested in pursuing at this time, or also if insurance is not covering this and paying for this for the testing. Next slide, please. It is important to note that for some indications, and in particular autism and developmental delay, Medicaid will require will cover microarray and Fragile X and not require a prior authorization. Next slide. Regarding management, it is not uncommon for families to believe that if a diagnosis is provided, that the long-term care and management will be through the diagnosing clinic or the genetics clinic. And that is oftentimes not the case. Rather, the long-term care and management is achieved through a partnership with the PCP or the medical home, other specialists, the family, and the geneticist. Next slide. There are many resources, condition-specific resources available for providers as well as families. And so I've listed, or I've shown a few here. Gene Reviews is an excellent resource for providers. We do have some families who want to dig in that deep, but also some such as Medline Plus, which was formerly known as Genetics Home Reference, is also a really nice family-friendly resource. But there are also providers who appreciate the information and how it's presented there. It's a nice way to get a quick view of the condition and then sort of get your bearings and then dive in a little bit deeper with something like Gene Reviews. But there are also disorder-specific resources as well, such as the National Fragile X Foundation, which is a really nice resource for families, not only on information, but also providing support groups and conferences and information about clinical trials, etc. It is important to note that each family is unique in their need for information and support and resources, and they're also unique in the timing of the need. So there are some families that from the moment a diagnosis is provided, they want as much information as possible and they want to connect with other families. There are other families that really need to take time to process the diagnosis, the meaning of it to them and their family. And then there are others who may never want or seek this information. But this can change over time, and so it is important to offer support and resources to families throughout the life course. Next slide. So in summary, and I have two slides after this, but to summarize the key points to communicate to the parents when they're being referred, when their child is being referred for genetics, and that is that the referral is made to evaluate whether a genetic cause may exist for the presenting features, and there's likely going to be a long wait before they receive an appointment. If genetic testing is recommended, then the sample, which is oftentimes blood, but sometimes we're able to offer other sample collection kits, but the sample will likely not be collected the day of the visit, and the results can take quite a while to return, and a genetic cause may not be identified, even though one may exist. If genetic testing does yield a diagnosis, the prognostic, management, and recurrence risk information may or may not be available. Oftentimes it depends on how much is known about the particular diagnosis. Patient and family autonomy will guide the decision to pursue genetic testing, and long-term medical management is a team approach. Next slide, please. This slide is intended to introduce two different views on ordering genetic testing. So on the one hand, there are some individuals that are of the school of thought that the PCP or a specialist may be considering ordering the genetic testing. And in fact, currently the pediatric residents are being trained that if they have a patient who is diagnosed with autism or developmental delay, they should go ahead and order microarray and Fragile X. However, as we will see in the fourth learning collaborative, the ordering the appropriate genetic test as well as interpreting and reporting the results is and can be complex. It's not uncommon for us to receive unanticipated or incidental findings. And so, and the patients need to know about that possibility prior to going through with the testing. And we also know that having an accurate and thorough phenotype can increase the diagnostic yield. And so there are others who believe that ordering genetic testing should be contingent on the ordering provider's ability to provide accurate and thorough phenotyping, to obtain informed consent about the variant interpretation and secondary or incidental findings, as well as being able to interpret and report the results. I'm hoping that we will, if we can go back, thank you, have a little more conversation at the end if you feel you would like to. About these different schools of thought, but I will leave this issue by reading a statement that was from the AAP clinical report that I showed at the beginning, one of the first slides came out in 2020, and that is this. The complexity of genetic testing is such that most PCPs may want to consult with a geneticist to plan testing and interpret results. The clinical etiologic evaluation should be tailored to the individual patient, taking into consideration information from the history and physical exam and the values and wishes of the family. Next slide. So this is my last slide, and really wanting to say that although the focus of this presentation was on a genetic evaluation for a child who is referred for either developmental delay, intellectual disability, autism, or dysmorphic features, there are other features that you may see in a child that are suggestive of a genetic condition. This list is not intended to be exhaustive by any means, but rather to give you an idea or a flavor for types of features. And so neurological features such as developmental regression, seizure onset, sudden or rapidly progressive hearing or vision loss. Differences in growth, so failure to thrive, undergrowth, overgrowth, asymmetric growth, segmental growth, short stature, tall stature. Cardiomyopathies that are not caused by viruses or progressive muscle weakness. There could be unusual dermatologic findings. So examples may be more than six or more cafe au lait macules, but also sparse hair or excessive hair, or abnormal dental findings such as conical shaped teeth or a significant number of missing teeth, primary or secondary. There could also be single or multiple major congenital anomalies, but also 3 or more minor congenital anomalies. Pediatric cancer, family history of a particular condition, as well as multiple miscarriages, stillbirths, and/or childhood deaths. And so, really the PCP plays a really important role in considering a genetic disorder in the differential diagnosis for an individual child. Next slide. And that's all I have, and so we're happy to take questions at this point.
Thanks, Sarah. And I'll turn it over to you, Jess, if you want to field questions. I know there were a couple comments that came in the chat. I don't know if you want to mention those at all. And then obviously, if anybody else has questions, please feel free to unmute and chime in.
Yeah, so I'll first do the question that came from North Dakota, Patricia Schwer, I should know how to pronounce that. The question really was, what can people do when there's little access to genetic services? She mentions in North Dakota it's a 9 to 12-month wait. I think Sarah mentioned that as a genetics group, we're quite aware that access is difficult, and unfortunately is difficult throughout the United States. I think that there are things that we're trying to do to improve access, and Dr. Berry mentioned that on the chat, where we really have a lot of hope that telehealth will be something that will allow more flexibility and will allow us to improve the number of individuals that we can serve. So I think we're hopeful for that. And I think also with having telehealth as an option, I think there's ideas that is there a way that we can do some sort of provider to provider consultation that could be helpful in these instances where you're thinking about doing a genetics workup for a patient. So I think we're thinking about that. I know that there are also a couple of systems that I've worked with where they have a genetic counselor embedded in the system that can be really helpful to the primary care physicians. If the primary care physician is interested in starting that initial genetics workup, and I don't know what other providers you have in your system, but that may be another way to try to improve some access to genetic services, or at least maybe start the workup. You can yourself, or oftentimes it can be really helpful to do that with a genetic counselor helping you navigate. Sarah, other thoughts or ideas on that?
My only other idea is, or thought is to know that there, on many different levels, there's effort to increase the workforce, but the pipeline is long, and so that isn't a quick fix. But there is a large effort to increase the number of individuals that are going into medical genetics, as well as to increase the number of training programs for genetic counselors. And so I think we are well aware of the issue, and there are multiple approaches to try and solve it, but I don't think any of the approaches will lead to a quick fix.
Yep, and it's another comment that came up on the chat is some of the expansion that we saw during the pandemic with telemedicine now is being pulled back because of different statuses of the public health emergencies in different states, and that's very true, and it's unfortunate. And, but I do think there are now a lot of examples of how telehealth and telemedicine can be really helpful. So I think, hopefully the work over the next few years, and unfortunately it may take years, but will be to improve systems so that we can make sure that all places have adequate ability to get access to genetic services.
Hey, Jess, I don't know if there's an additional question. I see Janet has her hand up. I don't know if that's in addition to your chat.
Yes, actually, I do have an additional question. And nice talk, Sarah. My question is, how do we rectify the difference of recommendations between the AAP and the ACMG? The AAP feels strongly that PCP should be ordering the Fragile X and microarray on every child with neurodevelopmental disabilities. But ACMG says, you know, unless you know how to interpret these results, you really shouldn't be ordering them. And so I guess my question is, when we're training the next generation of pediatricians, which do we follow? You know, because you know, a lot of people in PCPs may order these Fragile X and microarray, but they have no idea how to explain what the findings are. And then we run into the difficulty of getting into genetics.
So that is a question where you've got two different answers. I think my answer ends up more on the pragmatic side, because as we've mentioned, we're working hard to improve access to genetic services, but it is a long-term problem that we're going to have, and I don't think is going to go away anytime soon. So I think that if the pediatrician or family practice doc or other primary care provider does feel comfortable ordering genetic testing, especially microarray and Fragile X, I do think it's reasonable. I think the first step is to make sure that they feel comfortable with those two tests and how to consent the families for those tests. And I think that's an education piece. You know, I think that you know, if they have a geneticist and or a genetic counselor that they can work with to help them you know, feel comfortable with the consent process and the possible answers process. I do think that it is reasonable if they get a positive test, though, that they're going to need to then have a geneticist see it. And then we do run into the access issues, although I think if you have an abnormal genetic test, you usually get moved up in the triage process. Sarah, your thought?
Yeah, I guess the only thing I would add to that is that the microarray and the Fragile X are first-tier testing. So if that is ordered and the result is normal, or there's no no genetic cause identified, that doesn't mean that there isn't a genetic cause, and it doesn't mean that additional testing should not be recommended. And so my advice would be to keep that in mind just at the onset, and I guess that's part of the informed consent process, is having a discussion with the family about what the possible results could be and then what they might mean for next steps.
I just want to jump in quick and recognize that we are at time. I know there's still a few more questions and comments, and we're going to stay on and we'll keep on answering them. But this is being recorded, so if you need to go, make sure everybody realizes that we're trying to be respectful of your time. So Sue, I see you have your hand up if you want to go next.
The only other additional comment I would have, and we had a long discussion as we began this planning for this particular educational product, was that the other issue that ordering physicians ran into is insurance companies saying that they had to have a genetic counselor, a geneticist evaluation prior to ordering testing. And this was a tremendous barrier that was cited by the primary physicians who were helping us plan. We had exactly the same conversation about, should we teach people how, we started out saying we should teach people how to order the tests. And we ultimately ended up not doing that because of insurance issues, training and consent issues, and difficulty with interpretation. So it's a really difficult dichotomy to resolve.
All right. Any final questions from anybody that's still on for Jess or for Sarah? All right. Well, hearing none, thank you all so much for joining today. And Sarah, thank you for that spectacular presentation, and Jess for helping her pull that together and moderating Q&A. We really appreciate it. I guess everybody can expect to hear from Danielle soon with information about our presentation for next month on dysmorphology. And I guess we'll see you all then. All right. Thank you, everybody.